So I'm Ricardo Petraco. I'm a consultant cardiologist, interventional cardiologist at Imperial College London. So iFR is a resting index, instantaneous wave-free ratio, which is backed up by guidelines, not only for us to make decisions on whether a lesion should be treated, to defer and decide on treatment, but importantly on guidance on how to treat lesions, vessels, and opt for the best revascularization decision. So iFR is perhaps a modern version of what we use for tools in the cath lab to improve our guidance in revascularization procedures. So we moved in the last 15 years from using physiology to simply defer lesions or treat lesions. And iFR introduced a new era of physiological guidance where we can map the vessel, perform virtual PCI, and use physiology much more intelligently on not just on deciding whether the vessel should be treated, but how we should treat it, how long should the stent be, how many stents we use, and sometimes whether we need to put a stent at all or send the patient for a bypass. So it's a paradigm shift in the way we perform physiology in the cath lab, simply because it's a resting index that's been validated robustly over the last 15 years. And now with the most recent integration with Philips, we can put together the angiogram, the physiology, create a full map of physiological disease severity that helps many physicians make decisions better for patients in the cath lab. So the best value of iFR is not actually on a spot-on measurement for decision making. It's actually performing what we call the full vessel assessment. So once you decide that the lesion is potentially treatable, whether the lesion is severe, intermediate, or mild, you perform an iFR, and from then on, you perform what we call a vessel pullback, when you can decide within that vessel how we should treat it. And this principle of integrating physiology with anatomy, which we described as co-registration, is what has changed the way the physiology is used. So what is different from now to what was 10 years ago is that iFR is incorporated into pretty much every single vessel assessment, which enables to make intelligent decisions about how to put stents into patients. Yeah. So iFR is a resting index, and we have to remember this, the opposite of FFR used to be or still is, which is a hyperemic index. So we need to ensure that when we're measuring iFR, the patient is at rest, there's no hemodynamic stimulation, we're not giving them any drugs, no injection of saline, no nitrates, and you just let the patient untouched for 30 seconds and the patient goes back to what you call the baseline status. And this is the moment physiologically that you can perform iFR, pullbacks, co-registration, and trust the data you see in front of us. So the most common pitfall is to rush and press the iFR button too regularly and don't pay attention to the fact that the patient needs to be on their resting state for us to make those measurements. So I think the key thing is for us to move on from that mentality of using physiology just for a single measurement and defer lesions, but to incorporate iFR, the pullback and the co-registration in our day-to-day use of angiography. So physiology and iFR and the co-registration became an angiography-aided tool rather than a PCI tool. And we recommend that everyone who is introduced to the field of resting physiological measurements to do it again, repeat it in multivessel disease, and perform them before and after PCI. Once we start using it, once your colleagues start using it, you see there is a paradigm shift in the way you perform physiology in the lab, and you're going to start using more in more patients, and you become very much dependent on it to make decisions incorporating anatomy and physiology.